In Chapter 13, we'll be talking about domestic and economic policy. It's a very meaty chapter. We're going to go over some of the key issues in it. I will encourage you to read the text about policy making with the environment and immigration. We'll focus on healthcare as a policy making process example in this lecture. Domestic policy is the gathering of all laws, government plans, and government actions that concern important internal issues. Several types can be identified. 1. Regulatory policy defines what is and what is not legal. Redistributive policy transfers income between certain parties based on the belief that these transfers ensure fairness. And 3. Promotional policy fosters or discourages various economic and social activities, usually through tax breaks and subsidies. Let's use healthcare as an example of the policy-making process. Before anything can be done about American policy, the first step is to identify the issue and see that it's a problem. On rare occasions, a crisis leads to policy creation, but usually it comes from information provided by national media or lobbying groups. In 2010, the Obama administration's key program, the Patient Protection and Affordable Care Act, was signed into law. Several days later, the Healthcare and Education Reconciliation Act, a series of adjustments to the main act, was passed. Together, these two measures represent a massive overhaul of the nation's healthcare system and the largest expansion of the welfare state since the 1960s. First step in the process is agenda building. This is the effort of identifying a problem and getting it on the agenda. As I mentioned, this may come after a crisis or through the lobbying efforts of interest groups or others concerned about the problem. To talk a little bit about why healthcare is so important, the role it plays in the American economy. Spending on healthcare in 1965 accounted for about 6% of the national income. Now it accounts for more than 17%. In 2010, the government covered about 50% of total health care costs, the insurance industry covered 30%, and individuals and charities covered the balance of 20%. For about 100 million Americans, Medicare and Medicaid are the main sources of hospital and physician benefits. Medicare program, created in 1965, covers hospital and doctor expenses for U.S. residents over the age of 65. It's the nation's second largest spending program after Social Security, and it's paid for by a tax of almost 3% on wages and salaries. In 2006, it began paying for some prescription drugs. To contain costs, the government has placed caps on payments for certain procedures and has cut reimbursements to physicians and health maintenance organizations, or HMOs, leading to some reluctance by these groups to accept Medicare patients. The Medicaid program, created to cover expenses for the working poor, represents one of the largest expansions of government entitlements in the nation's history. It has greatly increased its enrollment and has more than doubled its expenditures since 1997. Jointly funded, the federal government pays for about 55% of Medicaid's costs, while the states pay the balance. In 2008, almost 16% of the adult population had no health insurance. This population is relatively young, since older people are covered by Medicare and younger people often have low-wage jobs with no health care benefits. Also, what we're finding is today's small business cannot afford to cover their workers. The traditional system in the U.S. was based on the assumption that employers would pay for benefits, but this is no longer true. The entire system is hurt by skyrocketing medical expenses. Costs have risen almost 5% a year recently, due mainly to expensive new technologies and practices. The growing elderly population needs the bulk of these services, indicating that federal health care spending growth is, and will continue to be, a Medicare problem. The Patient Protection and Affordable Care Act attempts to provide universal health insurance for all Americans. Most economically developed nations adopted such programs in the last century, and today the United States is the only advanced industrial nation in the world that has a large pool of citizens with no health insurance. Second step of the process consists of the debate that occurs among government officials and the public, and the media, Congress, and through campaigns. The idea of universal health insurance is not new. Liberal individuals have proposed national health care systems since the Truman administration, but most notably Bill Clinton during his presidency. Bill Clinton tried to do it, but he failed in his effort for universal health care. New plans don't really provide for a government monopoly on health care, but the mandate is that all citizens must obtain insurance from some source. That low-income families would receive a subsidy, and insurers could not reject applicants. And that was a similar program that was adopted in Massachusetts in 2006. Third step of the policy-making process, policy adoption. That's selecting a strategy for addressing the problem from among the solutions proposed. President Obama's delegation of the task and willingness to let Congress take the lead resulted in long deliberations and political maneuvering before the bill was passed. The plan proposed by Obama during the 2008 campaign did not require adults to get insurance, only children. But Congress quickly added to all legislation drafts the individual mandate that requires all citizens to obtain insurance. The most hotly debated provision in the plan was the public option. That's a government-funded insurance plan that would compete with the private sector. Supporters argued that it would hold down costs, but opponents, including the insurance industry, argued that private insurers could never compete with a government-backed program, and ultimately the public option was dropped from the bill. The program also would need taxes to fund it, but both sides argued over whether they would come from the rich or from drug and insurance companies. In the end, a compromise was struck. The initial proposal to increase taxes on the rich was modified and combined with taxes on healthcare corporations. Support was initially high for the policy, but it dropped quickly as Congress shaped the actual legislation. And many demonstrations were organized by the new Tea Party movement that had a significant impact on the policy-making process. The bill was finally passed by the House in November 2009 and by the Senate in December. Passing the legislation was more complicated since Democrats lost their 60-seat majority in the Senate in January 2010. But Obama and House Speaker Nancy Pelosi were able to gain enough Democratic support to avoid a conference committee and avoid a filibuster. The fourth step of the policy-making process involves activating and administering the policy by bureaucrats, the courts, police, and citizens. Many states are challenging the constitutionality of Obamacare in court. If the individual mandate is found to be unconstitutional, the practicality of the entire program might come into question. Conservative state officials have already refused to implement the legislation, but implementation plans are moving forward despite these objections. The final step of the process, groups both inside and outside the government evaluate the policy to determine if it has had the desired impact or if any unintended consequences have appeared. A new round of policy making can be undertaken if the current policy needs to be fixed.